recording.
Good morning, everybody. Today our class is the large intestine demonstration. So when you come to the practical exam, you will be see a heap of organs like this in a tray. This is the large intestine, and the large intestine is in between the ileocecal junction and the mucocutaneous junction of the anal canal. And now, large intestine, you have to first keep it in anatomical position. See now, I am separating these coils and trying to keep it in anatomical position. So now this is almost kept in anatomical position. We have seen that this is the ascending colon, then the right colic structure, then the transverse colon, and of course left colic structure. Coming down, it is the sigmoid colon. Okay, this is how a sigmoid colon looks like. It is having a inverted V-shaped mesocolon, and it is almost like a semicircle. Actually, sigmoid colon is having three parts: a vertical part along the right lateral wall of the pelvis, then a horizontal part that is going from the left to the right side, and then you will be having an oblique part that is coming from right side to the center of the rectum, which is present in the center of the body. Now this ascending colon, actually when you want to study the large intestine, you have to put this, I have to give this large intestine along with the cecum and appendix. So if you want to identify this large intestine, you have to look for the cecum and appendix, and after that you will be seeing the ascending colon, then the of course right colic structure, transverse colon, then the left colic structure, descending colon, and the sigmoid colon, of course rectum and anal canal. Rectum sometimes you may include, or sometimes you may be cutting to the sigmoid colon. So now the structures that are that are parts of the large intestine are, the first one is the cecum, and of course by the side of it appendix will be there. So cecum starts at the ileocecal junction. Cecum is about 6 centimeters length and 7.5 centimeters width. It's not here, I'll show you later in a figure. And then it is a storage part wherein the the completely digested and partly absorbed food is coming and getting stored in the cecum. From cecum, next is the ascending colon, which is about 15 centimeters length and 5 centimeters width. It is wider when compared to the other part, the transverse colon or the descending colon and sigmoid colon. So it is about 15 centimeters length and 5 centimeters width, and then it reaches the right colic structure, which is situated about 2.5 centimeters below the transpyloric plane and 10 centimeters from the midline. And then the transverse colon starts. It starts from the right side until it reaches the splenic fracture on the left side. It's, of course, it may not be straight, or it may be having some foldings or curvations like this. And then the descending colon. Transverse colon is about 50 centimeters length and 2.5 centimeters breadth. So it is very thin. I mean, the tube is very thin when compared to the tube of the ascending colon. Ascending colon is 5 centimeters width, whereas this is 2.5 centimeters. Then the descending colon is about 25 centimeters length and 3.5 centimeters breadth, and also sigmoid colon about 40 centimeters width and 40 centimeters length and 3.5 centimeters width. And of course, then rectum is 12 centimeters, then 3.8 kilometers, 8 centimeters, like that. So this is these are the various parts that you have to mention when you are given a large intestine. So starting from the cecum, ascending colon, right colic structure, transverse colon, left colic structure, then the descending colon, sigmoid colon, rectum and anal canal. So in addition to this, at the cecum, at the ileocecal junction, there is one more structure called appendix. Appendix is a vermiform appendix, that is a worm-like structure that is coming out from the cecum at the inferior posterior surface of the cecum, just 2 centimeters below the ileocecal junction, and this is about 2 to 20 centimeters length. It is not here, of course. 2 to 20 centimeters length, average 9 centimeters. It is a vestigial organ. It's a round finger-like structure. Now, the characteristic features of this large intestine includes the tinea coli. Tinea coli, see, these are the tinea coli, where I'll show you the tinea coli. Okay, here we are showing the tinea coli, this part. Actually, this tinea coli, we are seeing 3 tinea coli, which are nothing but the thickening of the longitudinal muscles of the large intestine. In the vertical parts, we call them as tinea libera anteriorly, tinea mesocolica posterior-medially, and tinea omentalis posterior-laterally. So here we are trying to show you one tinea, and in this section, in the next video, we will be showing all the 3 almost. And then, so here the tinea libera is anterior, tinea mesocolica is the posterior medial, and tinea omentalis is posterior lateral. Whereas in the transverse colon, as the direction has changed, the tinea libera becomes inferior and tinea mesocolica becomes posterior and tinea omentalis becomes anterior superior. And then similarly in the descending colon, we are seeing tinea libera anteriorly, tinea mesocolica posterior medially, and tinea omentalis posterior laterally. And this tinea, they converge onto the vermiform appendix and form longitudinal muscles of the vermiform appendix. Whereas onto the rectum, they are forming one anterior band and one posterior band. The anterior band is formed by the tinea libera and tinea mesocolica, the tinea omentalis, and the posterior band is formed by the tinea mesocolica. And apart from the tinea, we are having hastrations. See, you are seeing foldings of these large intestine. These hastrations are due to the fact that the 6 feet large intestine is inserted into 4 feet tinea. The tinea are about 4 feet length only, whereas this large intestine is 6 feet. So they are folded together to accommodate in 4 feet. So we are having hasciations which are making the interior like segments, interior of the large intestine like segments, which will increase the surface area for absorption of water and other things, and at the same time they will impede the speed of movements of this waste material in the large intestine. Then in addition we are having these are the appendix epiploica. Appendix epiploica are the peritoneal pouches into which fat is accumulated. Appendix epiploica are the peritoneal pouches into which the fat is accumulated. These are more common in transverse colon and sigmoid colon, and of course less common in ascending colon. So now regarding the interior, see here we are showing this tinea clearly. This is the tinea libra actually, and here it will be the tinea omentalis, and this part will be the tinea mesocolica, and we are seeing only the tinea libra more clearly. This part is the tinea omentalis, and here it is the tinea mesocolica. Now we are seeing this foldings of the large intestine, which will form shelves in the lumina of the large intestine. I am trying to show you tinea. And of course, this part, this is the tinea. So here we are showing the large intestine getting accommodated in the tinea and becoming folds. These folds are hasciations, are slowing down the flow of the food material, the waste material, and also allowing more surface area for absorption. Then same thing. We are trying to show you tinea coli again. So these are the appendix epiploica, the peritoneal pouches into which fat is stored. That much in practicals we have to first put it this large intestine in anatomical position. Then you have to identify the cecum appendix in the proximal end and ileocecal junction. Then you have to see the tinea libra, tinea mesocolica, and tinea omentalis. Mesocolica is easy to identify because the mesocolon will be attached to this tinea mesocolica, whereas tinea omentalis, sometimes you may see the omental part attached to the tinea omentalis, and the free one is the tinea libra. It's easy to identify these three tinea, and then of course inside you can show this the foldings of this large intestinal wall, hasciations, and they are attached to the tinea in the middle. And now this, because of this, we are seeing the folds of this large intestine, and then the appendix epiploica, I told you, the fat that is accumulated in the peritoneal sacs. And regarding the other things like where it is and what are the clinical parts, I'll show you. Oh, just I'll show you the interior of this cecum. So here we have cut open this. No, this is not cecum. No, I will show you. This is only cut open part only. I'll show you that's cecum interior in some other slide. Okay, now we'll make a review. Now large intestine extends from the ileocecal junction to mucocutaneous junction of the anal canal. It's about 6 feet long. Cecum is 6 centimeters. Cecum length is 6 centimeters and width is 7.5 centimeters. Appendix about 2 to 20 centimeters long and average is 9 centimeters. It is a vermiform, either finger-like or worm-like, and it will be the diameter will be very small. And colon is divided into ascending colon 15 centimeters long, 5 centimeters width, transverse colon 50 centimeters long and 2.5 centimeters width, descending colon 25 centimeters long and 3.5 centimeters width, sigmoid colon 40 centimeters long and 3.5 centimeters width, rectum 12 centimeters, senoid colon 3.8. Three salient features of the large intestine are tinea coli, sacrations or hastrations, and appendix epiploicae. So here I told you I will show you a typical large intestine. This is a typical specimen of the large intestine, which is having, see, this is the vermiform appendix, this is the cecum, which is broader than its length, and then we are seeing the ascending colon, this is the tinea coli, and of course these are the appendix epiploicae, that is the peritoneal pouches wherein fat is accumulated, and of course this is the hepatic flexure, then the transverse colon, sphenic flexure, descending colon, and the sigmoid colon. This part, this S-shaped is the sigmoid colon. Sigmoid colon is also a little broader, 3.5 centimeters width. So now the tinea in the vertical position, the tinea are tinea libera in the anterior surface, tinea mesocolica posterior medial, and tinea orbitalis posterior lateral surface. In the transverse colon, tinea libera lies in the inferior surface, tinea mesocolica on the posterior surface along the attachment of the transverse mesocolon, and tinea orbitalis on the anterior superior surface along the attachment of the posterior two layers of the greater omentum. Now of course this is the diagrammatic representation of the same thing. We are seeing the cecum, the vermiform appendix, the ascending colon, the transverse colon, descending colon, that's the sigmoid colon and rectum anal canal. Now cecum, we are seeing a right large saccule and a left smaller saccule. Tinea coli are three thick bands produced by the aggregation of longitudinal muscles of the large gut. Tinea are absent in the vermiform appendix and in the rectum. Each tinea coli is about 4 feet long, and into this 4 feet long, the 6 feet gut is inserted. So the surface of the large gut is sacculated or hastrated. This is the interior of the cecum, wherein we are seeing this. This is the ileocecal wall, which is like a transverse slit having a lower horizontal lip and an upper curved convex lip, and the opening of the vermiform appendix is a circular opening. Same thing we are showing again, the ileocecal wall, the appendix, And of course, here we are showing the hastras. That is the circulation of the transverse colon, circulation and appendix epiploica. This is the appendix epiploica are more number in the transverse colon and descending colon. And of course, this part is the sigmoid colon. Here we are showing the tinea coming and forming. This is the tinea libra and tinea momentalis forming the anterior band on the rectum, whereas this tinea mesocolica is forming the posterior band on the rectum. Band of longitudinals. Here you have arranged this in the anatomical position, wherein on right side we are having this cecum, vermiform appendix, ascending colon, of course this is the right colon picture, transverse colon, and of course left colon picture, descending colon, then this is the sigmoid colon and rectum. See, this part, the small intestine is entirely accommodated in this, the large intestine, which is surrounding the loops of the small intestine. And of course, this here we are showing this musculature of this tinea coming and forming the band on the anterior surface and the posterior surface also similarly will be a band. So here we are showing the vermiform appendix catching, and this is the cecum. The rest are the same. Here we are showing clearly the tinea coli, wherein the intestine is the circular wall of the intestine is in large intestine is getting inserted such that there will be hastrations, folds. Of course, this is the appendix epiploicae, the peritoneal pouch wherein fat is accumulated. See, this is the appendix epiploicae wherein fat is accumulated. These are the hastrations we have already shown. Traced proximally, all tilia converge towards the base of the appendix. Traced distally, about 5 cm above the rectosigmoid junction. Tinea unite to form two thick bands. Anterior band passes in front of the rectum and is formed by the fusion of tinea libra and tinea momentalis, whereas the posterior band is formed by the downward continuation of the mesocolica. Appendix epiploica are peritoneal pouches containing fat. They are absent in the cecum, appendix and rectum. So, this cecum, appendix and rectum are not having this appendix epiploica, and they are more in transverse and sigmoid colon, usually present between the tinea libra and tinea mesocolica. Now, each one, cecum length about 6 cm, breadth 7.5 cm, shape usually peridicid. See here, when you are telling that cecum is about 6 cm length, that is the cardocephalic direction, and breadth 7.5 cm right to left direction. You may be asked, what are the other structures which are broader than their length? So you have to say the liver, pancreas, vertebra. These are some structures which are broader than their width. You can add some more from the text. Types of cecum, fetal type, it is a conical, that is the end of the cecum. I told you, sometimes it is sacculated, a right saccule and a left saccule is usually 90%, whereas it may be conical, it is a fetal type, and infantile type it is a quadrilateral, and then normal adult type is sacculated. The right saccule is more enlarged than the left saccule. Position. This occupies a triangular area bounded by the transtubercle plane superiorly, inguinal fold inferiorly, and right lateral plane medially. So, the cecum occupies a triangular area bounded by transtubercular plane, that is the plane joining the two tuberosities of the iliac bone, and then inguinal fold. Of course, inguinal fold is that is the present over the inguinal ligament, and then right lateral plane that is extending downwards from the mid clavicle, right middle of the right clavicle. So this is the right plane, and this is the transtubercular plane, and of course there is the inguinal fold. So this part, the cecum is occupying this triangular area between the transtubercular plane, right lateral plane, and the inguinal fold. And here we are seeing the iliocecal junction at the junction between the right lateral plane and the transtubercular plane, and about 2 centimeters below that you are seeing the appendicular opening. Interior of the cecum shows iliocecal orifice in the posterior medial wall of the cecum at the junction of the transtubercular plane and right lateral plane. Appendicular orifice is a small circular opening situated 2 centimeters below and behind the iliocecal orifice. Applied anatomy in intestinal obstruction. If cecum is distended, the obstruction is in the large intestine. If it is not distended, the obstruction is in the small intestine. Intersusception of the ileum can occur due to the invasion of the terminal ileum into the colon and the ileocecal junction. So here we are showing the figure of ileocecal opening and the appendicular opening. This will be at the junction of the transtubercular plane and right lateral plane, and just 2 centimeters below that you will be seeing the opening of the vermiform appendix. So here this is the ileocecal opening of the ileum into the cecum, and this is the opening of the appendix. Actually, this ileocecal opening will be larger than this appendicular opening, whereas the appendicular opening will be circular. It will be looking like a transverse slit. The ileocecal opening will be looking like a transverse slit. Vermiform appendix surface anatomy. It is present 2 centimeters below the junction of the transtubercular plane and right lateral plane. That is, the base of the appendix is present 2 centimeters below the junction of the transtubercular plane and right lateral plane. McBurney's point represents by a point at the junction of the medial 2/3 and lateral 1/3 of the line joining the umbilicus and anterior superior iliac spine. So this McBurney's point is the one wherein if you press, there will be tenderness in case of the acute appendicitis, and that is present at the junction of a line drawn between the anterior superior iliac spine and the umbilicus, and the medial 2/3 and lateral 1/3 on the meeting point of the medial 2/3 and lateral 1/3 of the line. So that will be the McBurney's point. Length of the appendix increases in young adults and decreases after midlife, and commonest type is retrocecum. So here we are showing this McBurney's point is between the anterior superior iliac spine and the umbilicus, between the medial 2/3 and lateral 1/3 of this line. We are having the McBurney's point, and this is the base of the appendix, which is lying 2 centimeters below the point of intersection of the transtubercular and right lateral plane. Colon, ascending colon, hepatic fracture, transverse colon, splenic fracture, descending colon, and sigmoid colon are the various parts of this colon. And ascending colon is about 15 centimeters length and 5 centimeters caliber. Ascending colon lies above the transtubercular plane, whereas transverse colon, right colic fracture, is in right lumbar region, represented by a point about 2.5 centimeters below the transpyloric plane and 10 centimeters to the right of the median plane. Okay. And left colic fracture represented by a point 2.5 centimeters above the transpyloric plane and 10 centimeters to the left of the midline. Descending colon is 25 centimeters long, 3.5 centimeters breadth. It occupies the left hypochondrium, left lumbar region, and left iliac fossa. Sigmoid colon is about 40 centimeters length and 3.5 centimeters breadth. Has 3 parts. First part is vertically downwards along the right lateral pelvic wall, and second part is from left pelvic wall to the right pelvic wall, and third part is obliquely downwards from the right pelvic wall to the rectosigmoid junction. When the sigmoid colon is long and suspended by a long mesocolon, it may undergo a twisting and volvulus may occur. So here we are showing this is the transpyloric plane, and about 2.5 centimeters above the transpyloric plane and 10 centimeters from the midline, this part it will be the right hepatic flexure, whereas the left hepatic flexure will be about 2.5 centimeters below the transpyloric plane and 10 centimeters from the midline. This will be the left colic flexure. And then transpyloric plane, of course, is very important. It may be asked in orals and it may be a clinical question. So you have to read something about the transpyloric plane. This transpyloric plane is present midway between the suprasternal notch and pubic symphysis. This is the transpyloric plane at the level of the L1 vertebra, or it presents a hand's breadth beneath the Jiffy-sternum, or you may say it is present between the Jiffy-sternum in the middle of the line joining the Jiffy-sternum and the umbilicus. So first one is the suprasternal notch and the pubic symphysis in the middle, and the second one is the hand's breadth below the Jiffy-sternum, or between the line joining the Jiffy-sternum and umbilicus in the midway, where I have transpyloric plane at the level of the lower part of the L1 vertebra. So the other structures in the transpyloric plane are L1 vertebra, pyloric part of the stomach, pancreatic neck, duodenojejunal flexure, fundus of the gallbladder, ninth costal cartilage, hyla of the kidney, origin of the portal vein, transverse mesocolon, second part of duodenum, superior mesenteric artery origin, hilum of the spleen, and termination of the spinal cord. So these are the 12 to 13 points you have to talk when you are asked about the structures that are present in the transpyloric plane. So that finishes our class, and to have a revision, see this part you have to, when you cut open the cecum, you will be seeing the ileocecal junction and the appendicular opening. This ileocecal opening will be in the surface anatomy. It will be at the point where the transtubercular plane and the right lateral plane are joining, whereas just 2 centimeters below that the appendicular opening will be there. And of course, we have to talk about the various parts of this large intestine: the cecum, the appendix, the ascending colon, hepatic flexure, transverse colon, splenic flexure, and the descending colon, sigmoid colon, and the rectum. Of course, hastra we are showing. Then we are showing the appendix epiploicae. These are the appendix epiploicae, present almost anti-mesenteric border, which are accumulation of the fat in peritoneal pouches. And of course, tinea we are showing clearly. And this is the cecum. This is the cecum, and this is the appendix we are showing: ascending colon, transverse colon, descending colon, and sigmoid colon, and other things. And then again we are showing pointing the tinea. Then this is the appendix epiploicae. Okay, I have come back. So this is the diagrammatic structure, showing diagram showing the ileocecal opening, the appendix and its opening, then the hastra and the tinea. Tinea, this is the almost inferior one. No? There is the tinea libera, and this is the posterior one, the tinea mesocolica, whereas the tinea omendalis, which is present in the anterior structure, is present almost here like this part. And here we are showing this is the tinea, this is the anterior aspect, no? Tinea libera, and posterior laterally tinea omendalis. These are forming the anterior band on the rectum, whereas the posterior band is formed by the tinea mesocolica on the rectum. Same thing. So here again I am showing a typical large intestine, which should contain the appendix, the cecum. Of course, here this is the ileocecal junction, and then you will be seeing the ascending colon, then the hepatic flexure, the transverse colon, splenic pectoral, descending colon, and the sigmoid and rectum. Thing is that you should tell large intestine extends from the ileocecal junction to the mucocutaneous junction of the anal canal. It's about the 6 feet long and 1.2 centimeters. You can say the various parts and their lengths also. And of course these things. Okay, we'll end the class now.